Good afternoon and welcome back to our spring term of the weekly NHS Lothian Grand Rounds hosted by the Western General Medical Education Department. I'm Leslie Dawson, I'm the Associate Director of Medical Education at the Western General Hospital. Conor Maguire, my colleague in Medicine for the Elderly, and I hope that you are continuing to enjoy our weekly presentations, which can be seen by all NHS Lothian staff. I'm grateful to Gabby and Raquel for covering the IT aspects. As ever, we are building a programme of speakers from across NHS Lothian and beyond, from primary to tertiary care, and from a variety of healthcare disciplines. We are about to have a 2-week break for Easter holidays and hope to restart again on the 19th of April. We actually currently have a gap due to last minute change, so if you have a topic that you have a burning desire to share with us, please do email us and we'll find you a slot. As ever, we record the majority of our presentations, and these are uploaded onto the Medical Education Directorate website to form a useful library of information. You will need a login to see them. Today's presentation will take about 30 to 40 minutes, and we'll have about 10 to 20 minutes for questions and discussion. As ever, please use the Q&A bar on the right-hand side of the screen. Put your question in there, and if there's a question that somebody's asked that you like, use the thumbs up sign. This allows us to prioritise questions if we are short of time. I'm delighted that we are joined today by Professor Matt Reid, who's the Honorary Professor of Emergency Medicine at Edinburgh University and the Royal College of Emergency Medicine Professor of Emergency Medicine. He leads Emerge, which is a clinical research group that aims to ensure that research is part of everyday clinical care, with a focus on research in challenging areas of emergency and acute care, where novel technology can impact on healthcare. Matt has a unique personal experience of his main area of research, that of transient loss of consciousness, although his was probably due to something that would come very low down the differential diagnosis list. In other words, losing consciousness while skydiving as a medical student. He wasn't trying to play the cello at that point. He tells me that his cello skills are worthy of the really terrible orchestra. So we're not expecting him to be soothing the long queues in A&E anytime soon. Today, however, he's going to talk about using novel technology to diagnose cardiovascular disease in the emergency department, and is having a crash course in overcoming his fear of the technology of Teams. So I'm going to hand over to you now, Prof.
Thank you so much, Leslie, for the introduction, and thank you ever so much for the invitation to speak today at the Grand Round. So I'm going to speak to you about the use of novel technology to diagnose cardiovascular disease in the emergency department. But before I get onto that, I just wanted to spend 10 minutes giving you a bit of background about Emerge and also about research in the Royal Infirmary Emergency Department. So first of all, here are my disclosures, which are all related to some of my novel ambulatory device work. The iPad study, the Patch ED and the Aspire studies, which I'm going to mention, are all non-commercial studies which are independently funded through research grants. So when I was asked to do this presentation, it took me back and I was reminded of my first Grand Round as a house officer in Cambridge, where I was given the unenviable task of discussing the treatment of hepatitis C associated glomerulonephropathy with mycophenolate, a drug I hadn't heard about up to a few months before. And this was in front of a huge number of medical professors who knew more about it than I did, despite my weeks of preparation. In those days, you had to prepare a carousel of slides up to a week before, which you had to hand in. So how things change. I'm now sitting in my study at my house and I'm talking to you all on Teams. So this is where I work. This is the emergency department at the Royal Infirmary. As well as my clinical work, I also have some NRS research time to promote and support recruitment, both to our own studies and to studies of our colleagues around the UK, and also to develop our own research portfolio. As you may well realise, the emergency department is a busy place, and this has been well publicised over the last few months. In Edinburgh, we regularly operate with half of our space taken over with patients waiting on beds, and we regularly have more than 100 patients in the ED at any one time. Yet, Despite this, year on year, our research team managed to increase the number of patients who were given the opportunity to take part in emergency medicine research in Edinburgh. Initially in the adult ED, but now also at St John's under the leadership of Stephen Lynch, and at the Royal Hospital for Children and Young People led by Jen Browning. This is Team Emerge. We're committed to providing the highest quality evidence-based care to all patients attending the ED, to promote academic emergency medicine across the UK and to support our trainees and our staff on their academic journeys. We strongly believe that research should be seen as part of providing excellent clinical care to all of our patients, and we aim to ensure that research activity is seen as being integral to improving patient care. Why do we believe this? Well, it's well established that hospitals that have flourishing research programs provide better clinical care to their patients. In Emerge, we aim to provide every patient that attends the ED the opportunity to take part in clinical research where it's available and when there's a relevant research study. So how do we get to the point where we now recruit over 5,000 emergency department patients a year to research studies? This is by far the most for any emergency department in the whole of the UK. Taking you back a little bit, this is Keith Little on the left there, Colin Robertson, the bottom right, and David Steedman, bottom in the middle there, who established emergency medicine at the Royal Infirmary. And this is Keith in front of the first Medic One vehicle, which was an innovation at the time when it was first used in and around Edinburgh. And talking about innovations, one of our medical students recently wrote a history of the emergency department at the Royal Infirmary of Edinburgh and did some interviews with some of the founders of our department. He wrote, in the 1970s and 1980s, the emergency department was seriously understaffed. The sheer unpredictability of emergency department work often complicated attempts to match staffing arrangements to the workload. This could almost be written today. He goes on, however, once the emergency department became more structured, there were vast opportunities for high-grade clinical research, potentially yielding new diagnostic and investigative procedures which may become routine in the future. So what were these new diagnostic and investigative procedures which may become routine in the future? Well, back in the 1980s, we were discussing treating sick patients in a special area of the emergency department called the resuscitation room and putting defibrillators in the back of ambulances. This was novel technology for cardiovascular disease in the 1980s. Our department has always had a research culture, and huge amounts of work followed throughout the 80s and 90s in areas such as cardiac arrest, pre-hospital medicine, and emergency respiratory conditions, mainly around asthma. By 2008, it was time to better formalise its activity. So 7 of us got together in the back of the Candyman's pub in Edinburgh's Morningside. I'd like to point out that not all Emerge research meetings take place in the pub. Anyway, we decided that we needed to set our own agenda, we needed to form our own brand and identity, and we needed to prioritise research that was important for our patients and for emergency medicine. So we decided at this point to establish the Emerge Emergency Medicine Research Group. Today, we collaborate with a huge number of clinicians across the hospital on front door research, and we collaborate with every specialty who deal with patients presenting with acute conditions on a huge number of front door studies. If you're considering a research project that involves patients who attend the hospital through the ED, please come and see us early so we can help you design the study so that it will succeed in the very difficult environment that we practice in. We now have between 20 and 30 research studies running at any time on our books, a combination of homegrown studies, UK portfolio studies led by emergency medicine colleagues elsewhere, and commercial work. My personal area of interest is in primarily syncope, also known as transient loss of consciousness, and I'm specifically interested in the prediction of adverse events in patients after they are presented to the ED with an episode, and in using novel ambulatory monitoring technology to predict abnormal heart rhythms or arrhythmias. So I'm going to start talking about syncope first of all, firstly describing what it is, and then discussing why ED physicians sometimes struggle to manage it. I'll talk about the current approach we use, and then talk about some of the future focus using novel technology to make the diagnosis. To put syncope into context, it's responsible for around 400,000 of the almost 30 million presentations to UK EDs, and it just falls out of our top 10 commonest presentations to the ED at the Royal Infirmary. So what is syncope and why is it so difficult to manage? So syncope is a short-lived loss of consciousness with complete recovery that is due to a temporary reduction of blood flow to the brain. The three main underlying causes: reflex or vagal, similar to a simple faint. Second is a postural episode, so this is related to prolonged standing or a patient standing up and then having a blackout, or cardiac being the third main cause. And heart-related causes can either be structural, so this might be something like aortic stenosis, which stops the flow of blood out of the heart, or it might be due to an abnormal heart rhythm, such as complete heart block or ventricular tachycardia, which interrupts the blood flow from the heart to the brain and causes loss of consciousness. There are some rare causes of syncope, which most clinicians in the emergency department will be unlikely to see in their practicing lifetimes, but do cause us a huge amount of stress. We sometimes have the opportunity to pick these up and prevent the unfortunate events that these rare causes can then lead on to, such as this. So this is Fabrice Maramba. You may remember this case collapsed during a FA Cup game between Bolton and Spurs. And he underwent tests and was diagnosed with hypertrophic cardiomyopathy. And this is the commonest cause of congenital heart disease, but again, something most of us are unlikely to see in our practicing lifetime. Some patients with poor cerebral circulation normally may have slight confusion after syncope. However, the majority of patients are back to normal, irrespective of the underlying cause, which, when they come to the emergency department, makes it very hard to pick up what caused the episode. Unlike this poor weather forecaster, syncope is commonly unwitnessed. The patient has little recollection of events, and therefore making the diagnosis can be really difficult. Commonly, we don't have a relative in attendance, and sometimes we don't have an ambulance patient report form to be able to help us, or the poor unfortunate cashier in Marks and Spencer's or wherever this happened. So sometimes that can involve a bit of digging around. And because the patient is unconscious, the only way to pick up an abnormal heart rhythm is to be continuously recording the patient and their ECG during the time that they have the event. So our management and follow-up in the emergency department traditionally has depended on deciding how likely the patient is of having a cardiac cause, so risk stratifying them. And that's if we don't have the obvious cause in the emergency department. So sometimes we're lucky and a patient might come in with an ECG showing complete heart block, but if they're back to normal, there are no signs of anything on examination, their ECG may be normal, we have to risk stratify them, and we look for high-risk features. And if the patient has these, we'll either admit them to hospital or arrange outpatient follow-up. If the patient only has low-risk features suggestive of maybe a reflex cause or postural cause, in the absence of any other reason to come in hospital, we'll probably discharge them from the ED. However, that's what we've been doing in the past, so risk stratifying patients. But I think now, in the era of personalised medicine, we should be doing much better for these high-risk patients in whom we're worried that an abnormal heart rhythm might be the cause of their event. So many patients, if they're admitted to hospital, they tend to come into a ward for 24 hours. They're commonly not monitored due to our lack of monitored beds. So they don't have their abnormal heart rhythm picked up in hospital, and they end up waiting a long time for monitoring tests. So what's been holding us back? Well, one of the reasons is that, unfortunately, the technology hasn't really developed much further than when this gentleman, and this is Norman Holter, he started work in the late 1940s on ambulatory ECG monitoring. You can see from the photo that at that time it wasn't very portable. The key component of the initial Holter monitoring was a Second World War radio pack, which you can see him wearing on his back there. The technology we currently use is not that much better. So the Holter monitor that was developed during the 50s, this is a much later version of it. And this is something very similar to what we're using at the moment. And although we can record up to 5 days, commonly we're only using 24-hour Holter monitorings. And as you can see, these type of monitoring devices are not compatible with daily life, swimming, showering, running, and the like. At last, though, the technology has caught up, and there are now some ambulatory ECG monitors on the market that can continuously record a single lead ECG for up to 14 days. And these can be worn as a patch, and they can be worn while showering and while the patient's living their usual life. So can this technology be used from the ED? And can we reduce the number of patients who are admitted to hospital? And can we enable earlier diagnosis in this patient group without over-investigating patients because we're intervening so much earlier? So initially, we looked at this with our study, the Patch ED study. So we took 86 patients from the emergency department who had unexplained syncope. That is those patients who, after their emergency department visit, we hadn't identified a cause in the ED. And we fitted them with an ambulatory ECG recorder that was able to record their ECG while they're going about their active life for 14 days. And our USP here is that there's some evidence that if we monitor people as soon as after their index visits, as soon as after their initial blackout episode, then we have an increased chance of picking up the underlying rhythm. And also we're monitoring for much longer than is standard. So for 14 days compared to 24, 48 hours. So in 56 of the 76 patches that we had returned to us, we had found a diagnostic rhythm. And 9 of these were for serious heart rhythms, or these were arrhythmias, cardiac arrhythmias, serious ones that occurred whilst the patient had symptoms. And also we were able to pick up patients who had symptoms while wearing the device and recorded normal sinus rhythm. So we're able to say that it was unlikely to be a cardiac arrhythmia causing their syncope. And they may have had other causes. For example, it might have been a postural episode or a vagal reflex episode, but we were able to fairly confidently reassure them that they had the episode, and at that point there was no cardiac arrhythmia. So this demonstrated to us that in the group of patients whose syncope is unexplained in the ED, they do have a burden of disease that was sufficient enough to warrant further investigation. We looked at where these events occurred over the 14 days, and we found that whilst a lot occurred earlier on, which some very early evidence was suggested was a better time to pick these up, that these were right out to 2 weeks, really showing that prolonged monitoring was going to be up to at least 2 weeks to be beneficial to have its maximum yield. So this is Rob. He's one of the patients who was enrolled in our study, and he presented to the ED with syncope without any prodromes, had no warning whatsoever. And he had significant trauma during his episode. He was carrying a cup of hot tea at the time and spilt it over his chest and ended up in the burners unit. So we enrolled him to the study. We placed a 14-day device on him, and his ambulatory device showed he had a 26-second pause where his heart had no ventricular complexes for 26 seconds. And this was an event he had 4 days after his initial presentation. So we brought him back to hospital, we placed a pacemaker in him, and since then he's had no further episodes and is one of our PPIs, a real advocate for our work. So I'd like to play a short video by Rob to demonstrate the profound effect that recurrent syncope can have on patients.
Hi, my name is Rob Hannigan. I'm from Newtownards originally. I've been in Edinburgh for 20 years. I have two family members, a daughter and a son, and I'm here to talk about the PatchEd trial. Well, my story began in April 2016, where I fainted twice in the space of 3 days in the house. I hadn't had any injuries or any fainting spells before, and this is the first time it happened. And suddenly I've gone from being a healthy, youngish man, with a young family, with no concerns, no worries, to being potentially incapacitated, housebound. Self-confidence was taken away from me. I was babysat by people. I couldn't be left by myself in case I fainted without any warning. And the realization that this could be my life until I get this resolved was frightening, absolutely frightening. A young family that I couldn't really do anything with, concerns, could I ever work again? Could I ever drive again? Could I ever, be a husband again? That was the physical element of the burns heal, but it was that mental anguish that I felt from falling over the third time to getting the results, was a horrendous period for me. And then you sit down and you get the results, and you're told that within the first 4 days of the trial, your heart stopped beating 4 times. 3 of them were for 3 or 4 seconds, which can be explained. 1 of them was for 25 seconds. The patch-head trial and the results of that, and the surgery has given me my life back. It's given me back the opportunity to have a future with my family, to see them grow up, to have the confidence to be able to go and do simple things like go out for a walk by myself, go back to work, and to lead a normal life. So these are gifts that you just have to grab. Hi, my name is Rob.
So now with Rob's help, we've managed to secure a grant from the BHF to fund a UK randomised controlled trial of a 14-day heart monitor, which we're starting in the ED. And we're comparing this to standard monitoring in over 2,000 patients who present acutely with unexplained syncope, to see whether it first reduces the number of episodes that patients have, so a very patient-centred focus, and also whether it's cost-effective. We started in July 2022, and we're already seeing many more patients like Rob across the UK who potentially might be benefiting from this technology in the ED. So moving on from syncope, I'd now like to talk about palpitations. So palpitations is the perception of rapid or irregular pulsations of the heart, skip beats, fluttering or pounding in the chest. They're common symptoms. Most are due to an increased awareness of our normal heartbeat, or to normal irregularity of our heartbeat due to ectopic beats. And you all might have noticed these when you're lying in bed at night when it's quiet, and these are normal, but there are in about 15% of patients palpitations that can be due to an abnormal heart rhythm. Again, another common ED problem. It's important that we focus our research on problems that we see commonly in the ED, and you can see this one does make our top 10 of commonest presentations to the Royal Infirmary ED. Now, most patients' palpitations have resolved by the time they come to the ED. If they do have an underlying abnormal heart rhythm, it's normally gone back to normal, so their ECG is normally normal. And if they did have an abnormal rhythm, it's more likely to be a less serious rhythm than with syncope. So something like atrial fibrillation, atrial flutter, or SVT. So these are less likely to cause loss of consciousness, but they're no less distressing for patients. So previously in the ED, we didn't really have much more to go with, really. So we had to discharge patients home, telling them that there was a potential this could have been a cardiac cause, and to try and come back to us if they had more symptoms, to go to the GP or for an ambulance, try and get an ECG while the episode was actually happening. And unfortunately, we persisted on still giving these patients the 24-hour monitors, which very rarely captured an episode of palpitation during the monitoring period, which was obviously falsely reassuring. So how are we going to tackle this? Well, I'm going to take you back to August 2015. It was a Friday evening, and that afternoon I'd seen 2 patients in the ED, both presenting after having palpitations, and both of them had settled by the time that they got to the ED, and both were sent home with the advice as I suggested. I was really frustrated we couldn't offer them anything other than device that we need to capture on ECG and to represent should this happen again. Now, that evening, I've been visited by some friends, Chris and Nigel. They were off to do the original mountain marathon, and they were priming their Garmin watches. Those of you who do a bit of running might know what a Garmin watch is. And it got me thinking, is there anything out there like this that includes ECG? And the Garmin doesn't. So I declined their kind offer to run 100 miles that weekend and instead did some Google research, and I stumbled across the AliveCore. Could we use this in RED? Could we use this in our palpitation patients? So this new kid on the block, the AliveCore. So this is it here. It relies on the fact that, unlike syncope, patients with palpitations are conscious when they get their symptoms. They therefore don't need to be continuously monitored, and they can use technology that can carry it around with them like this in their pocket or in their handbag, and it can be taken out and you can record an ECG when you get symptoms like this. So the patient put 2 fingers onto the device of both hands. So this is recording a 1 lead ECG, which you can see there. It's not too bad. It's my ECG at the moment. Not bad while giving a Grand Round presentation. So first thing Monday morning, after Chris and Nigel's visit, I wrote the grant, and 2 months later, we found out we'd been successful. 2 further years, and thanks to some amazing colleagues around the country, we completed the iPad trial within time and with a budget of less than £50,000, which is pretty good for a multi-centre trial. So in March 2019, the iPad, the investigation of palpitations in the ED, was published in a Lancet journal. So we randomised 243 patients who presented with palpitations or near claps, so not syncope, palpitations and near claps, who were undiagnosed after their ED attendance, and we recruited patients from 10 EDs around the UK. And we either randomised them to using the AliveCore device or to standard care, which in most hospitals is the Holter monitoring. So we randomised 126 patients to the intervention, that's the AliveCore device, and 117 to the control arm. And you can see, so there was a slightly more females, which is fairly common with palpitation presentations, and the majority of patients were palpitations compared to pre-syncope, which is a feeling of a near faint. Our primary outcome was the percentage of patients in each group who recorded a symptomatic rhythm. So that's the number of patients who recorded an ECG whilst they were having their palpitations during the study period, which was 90 days. And therefore, that would allow us to make a diagnosis of what the underlying rhythm was during their symptoms. If they had a cardiac arrhythmia, then we knew that's what it was. And if while they were getting their symptoms, they had a normal sinus rhythm, we could be reassured that it wasn't a cardiac cause. So 55% of patients in the AliveCore group recorded a symptomatic rhythm but after 90 days, and compared to only 10% in the standard care group. We broke down the rhythms that were picked up, the symptomatic rhythms, and you can see that about 13% had a cardiac cause, and this was mainly atrial fibrillation or SVT. About 13% were getting regular ectopic beats, which were explaining the symptoms, and the rest had a normal heart rhythm during their symptoms, which was reassuring for showing that the cause of their palpitations was cardiac. So this is the time it took for patients in both groups to detect a symptomatic heart rhythm. So those who had a symptomatic rhythm in the intervention group were picked up at around 10 days, and it was around 6 weeks in the control group. We looked at the number of patients who had a symptomatic cardiac cause, so how many patients in each group had atrial fibrillation or SVT, for example, picked up. And in the AliveCore group, 9% of the patients had a cardiac cause compared to less than 1% in the standard care group. Now, with a randomized controlled trial, you're randomizing people to both groups, so we expect roughly an equal number of cardiac arrhythmias in both groups. So from this, we could say there's probably still around 10 patients walking around in the control group who still had an undiagnosed abnormal cardiac rhythm, which was causing their palpitations at the end of the 90 days. We looked at cost effectiveness, extremely important, obviously, and we found that the intervention was cost effectiveness, and this was mainly due to reducing ongoing testing, further 24-hour monitoring that didn't pick up the diagnosis, and repeat ED and hospital attendances. Patient satisfaction, obviously hugely important as well. Participants found the device easy to use, and they found it was available when they had symptoms. So since publication of the IPED trial, we now have introduced in the Royal Infirmary a smartphone palpitation service. So this is for emergency and acute medicine patients who present with palpitations, who we don't have a cause in the ED. We discharge them home, they return to the ambulatory care clinic, and there they're assessed by the team there, so Ross Murphy, Val Pollard, Goran Zangabab and Pat Holdsworth, the team down there, and they see these patients, and if appropriate, they fit them with the AliveCore device when they come back to the clinic, normally the following day. Now, in the IPED trial, we found that 93% of the patients who recorded a symptomatic rhythm did so during the first 28 days of the 90-day studies. Therefore, to improve turnover of the devices in the clinic and allow timely treatment to the patients, we bring patients back after a few weeks. And those who haven't recorded a symptomatic rhythm at 4 weeks can be re-reviewed after a longer period of device. And clearly there's the potential to do this much more remotely to save patients coming back. If they haven't recorded a device, they can hang on to it until they manage to have an episode where they can record the underlying rhythm. We audited the first year of our practice, so this was between July 2019 and July 2020. We referred 290 patients in the year to the clinic. We fitted 237 with the device when they returned to the clinic, and 17 of those were diagnosed with a cardiac cause. So very similar to the numbers we were picking up in the IPED study. And the majority of these, as we would expect, were all atrial fibrillation and SVT. And these are clearly important because patients who have recurrent atrial fibrillation are at risk of stroke and need assessment for stroke prevention. And SVT, again, is something that can be very problematic, very life-affecting for patients, and there are treatments available such as cardiac ablation to be able to reduce the risk of symptoms. And reassuringly, in 200 of the patients, we found a normal heart rhythm during the symptoms, which was able to tell us that the cause of the palpitations in these patients was reassuringly not cardiac. And back of this work and that of others, last year, NICE deemed the AliveCore device suitable and cost-effective for the detection of AF in patients with palpitation. And in the last few weeks, the Scottish Health Technology Group have also published similar guidance that the AliveCore device is suitable for monitoring patients with palpitations. So this has now become standard practice across the UK through NICE, and I'm sure we'll be seeing it used in clinics such as ours much more across Scotland. It's not the only way to record an ECG, the AliveCore. Those of you with an Apple smartwatch can now record themselves being in AF, and if necessary can receive stroke prevention if required. I sometimes wonder what Norman Holter with his radio backpack would have thought of this many years later. So to finish, I started by telling you a bit about the emergency research group in Edinburgh, and a bit about our strong belief and ethos that research should be seen as being integral to providing excellent clinical care to all of our patients. I then talked a bit about how we struggle in the ED with diagnosing two very common cardiac complaints, those of syncope or blackouts and palpitations, and how through research into novel ambulatory monitoring techniques, we're trying to improve how we diagnose these patients and how we subsequently improve patients' experience who are unfortunate to have these conditions. And the blackout during skydiving, well, as a 25-year-old medical student, I did have a transient loss of consciousness during a skydive in New Zealand, and had this very impressive carpopedal spasm on landing that made the country's medical journal, thanks to my other medical student colleagues who were there and witnessed me coming into land in the non-preferred position of head back and legs flailing below me, unbeknown to the person I was strapped to. So this was luckily a tandem skydive and not solo, so I did live to tell the tale. And the cause was reduced venous return thanks to the tight leg straps I had strapping me to the person who was doing all the proper skydiving. So thanks for the invitation again to speak to you today. I'm more than happy to take any questions that you have. Thank you.
Thank you so much, Prof. And it's great to be able to celebrate your appointment to chair. It must feel great to be able to actually give some people an explanation of why they are having syncopal episodes, rather than going, it's just a feint, we'll see what happens.
Absolutely, yes. I think it's something that traditionally we haven't done particularly well in the emergency department. These patients tend to be sort of grouped into the category of sort of collapse query calls, which is something that's sort of I think not very helpful, rather than actually trying to get to the bottom of exactly what happens. And the doctors in my department will be fed up of me asking them exactly what they mean by feeling unwell, whether they mean vertigo, whether they mean syncope, to try and get down to exactly what happens. But even then, as I said, a lot of these patients we don't have a cause for, and traditionally we haven't really done very well with managing them. There's no particular specialty that looks after syncope. So the cardiologists get involved with the more serious causes. Older patients with postural episodes are really well looked after by the geriatric teams, but it's not something that we particularly manage very well, and it's quite unsatisfying just sort of to be able to risk stratify patients, and I think we can do much more for them.
And the device that you used in the Aspired trial, patients still have to bring that back, do they?
So they do, yes. They take it, they either take it away with them or we post it out to them. They fit it, they wear it 14 days, they put it back in the post, and it goes back to its Preventus we're using for this trial. There are other devices available on the market, but then it's reported and it gets uploaded to the team. There are some devices, MBOT type devices, which sort of mobile telemetry, where they can feed directly by Bluetooth to a little box in the corner, and that can alert their team to it. We don't use it particularly, certainly not in acute care in the UK. I know cardiologists use it a bit more. It's maybe used a bit more in North America. It's more expensive. It's harder to fit, obviously, and it's more expensive. So you probably only want to do this with patients who you really are particularly sure they have a cardiac cause, and who you're worried about that, you need to know at the time they've had the episode. So there is a risk, obviously, that we will record some fairly serious cardiac arrhythmias in this group, but the care we're providing is far better than the care we provide at the moment.
I suppose, Rob, who did your film, is the extreme example. I suspect there was a lot of tachycardia in the department when that was analysed, and you saw that pause that went on and on and on and on. And I suppose what I'm thinking about is ultimately if you had semi-real-time feedback, somebody, and without creating work for cardiology or worst case, an extra monitor in coronary care, when you see that pause, somebody phoning him and saying, "Get yourself in here now, please, thank you very much," or sending the crew around to just make sure that he was still conscious.
Yeah, absolutely, and that is the real balance with this, because since doing some of the work, it's really an eye-opener to me to how often normal people have very short runs of things like SVTs. So all day, all of us have a couple of beats of SVT every so often, and it's totally normal and unworrying. And we're obviously picking up some of this stuff, and it is benign. And the balance is between worrying the worried well and increasing anxiety, and increasing workload on cardiology, which is absolutely not our goal here. And we've got some excellent collaboration with the cardiology team at the Royal, who are really supportive of this, but we don't want to do that. So we have to have a threshold, and that's what this trial is about, really. It's making sure that we're not over investigating, picking up lots of stuff that isn't the relevant cause, whilst hopefully being able to actually diagnose patients who have problems. I do remember I actually phoned Rob myself when I got the report back, and he was actually at I think his child's award ceremony, which was the first time he'd been out of the house since this had happened, and was so anxious during it the same thing was going to happen to him. So rather than me, I felt bad interrupting him during this, but he was absolutely delighted that he could come back in. And it was one that I didn't worry about phoning the cardiology on call to say, what do you want us to do with this? They were more than happy to bring him straight back and admit him to cardiology.
And I mean, we're quite a lot of people now wear Apple Watches and they've got the AFib detector. Have you had anybody come to ED who's been able to pull up a trace and make your life easier? Because obviously that is where technology is going, and certainly, you know, Hannah Fry, when she was doing her taking modern gadgets to bits, talked about heart traces and future developments. I think she went off to Silicon Valley to talk to somebody about where Apple Watch technology and similar smartwatch technology might be going.
Yeah, absolutely. We I think we'll become experts in knowing how to get an ECG off an Apple Watch, because we have had several patients coming back having recorded atrial fibrillation on their smartwatch, and again with the anxiety that's brought, and obviously wanting reassurance at the time, and obviously started on the right treatment. So yeah, that is, there are, obviously we're aware that with this technology, it isn't available to everybody, so it does rely on people having a iPad or iPhone. These things are not cheap, so really looking to other ways where we can make this clinic and this care more equitable. And we're looking at, along with Neil Grubb, a device called the O-Heart, which is neat little device from a startup, which is basically just a little bracelet with a button on it that doesn't have to have a smartphone. So patients can just press the button. So we can issue them with this, they press the button, and then it can be uploaded later on. So it's much more equitable in terms of care. But yeah, more than 90% people actually have phones. I should say it's not only Apple, all smartphones actually LiveCore is compatible with, but more than 90% of people have it. And in fact, elderly patients are a group that up to 75, more than happy to use this technology, most of them. So age isn't really a big problem, and I'm certain as we move on, that will go from 75-year-olds to 80-year-olds to 85-year-olds. So it's a technology that is that older patients are happy with as well.
And obviously stops people being admitted to hospital and thereby deconditioned. You can actually let them go home with that, with the confidence that their remote monitoring will happen. So Rustam, I think having mentioned your scary grand rounds, Rustam Salman has said the only thing more intimidating was the Gowers round at Queen Square. So I assume that was some hideous, complicated neurological fascinomas that used to have to be presented. How comfortable were you randomizing people, given the fact that obviously arrhythmia was high yield and of significant clinical impact?
Yeah, I mean, that's an excellent question. That's one that our research nurses struggle a little bit with, because this is probably one of the studies that I have done that has the best uptake with patients. So patients want an answer solution, and we've had almost 95% uptake in patients. wanting to take part, and they read the patient information sheet. They think that's brilliant. Yeah, really like to do that. Yep, someone's interested in what's wrong with me, and then you randomise them, and they get randomised to standard care. And you say, "I'm really sorry. See you later. Standard care for you." And unfortunately, it is part of these type of trials. But with all this type of technology, it's really important that we not only look at whether we're picking up more rhythms, but really patient-centered outcomes. So does this translate to then us being able to treat and manage patients better and reduce their episodes and improve their quality of life, and also make sure that it's cost effective as well, because there's a lot of technology around, a lot of technology in the market, and we need to make sure that it is not only is cost effectiveness, stop people being admitted and having to have unnecessary tests, but also that it's actually improving a patient-centered outcome as well.
Yeah, I think that we all like new technology and new bits of kit, but it's being sure that actually it's clinically doing what you want it to do. But and as you said, we're not creating additional stress for people who might otherwise be well.
Yes, absolutely. And we've noticed a lot that since COVID, probably that certainly the presentation of palpitations has certainly gone up a lot. Whether that's an increased awareness of patients' own health, whether there are more patients experiencing palpitations, whether that's through COVID or not. I think probably just health anxiety and health awareness has increased since COVID, and that's probably that. And that's the challenge, and we're very keen that the patients we bring back to our clinic are those that the clinician is actually considering a cardiac cause, because a lot of these patients are having multiple episodes a day over multiple days. We don't need a device such as this to pick it up. We can monitor them for a couple of hours in department and work out what's going on. So it's how to get that right patient back and investigate the right patients, which is a challenge.
You obviously talked about the footballer, and every so often we hear about people who are fit and healthy and athletic and undertaking high level sports. Has there been any discussion with sporting bodies about not only screening people with ECGs for HOCM, but perhaps using something like this to monitor people when they're actually playing sport, to pick up people who are perhaps at more risk of significant arrhythmias?
Yeah, it's not something I'm involved with, but I know obviously there is a huge increase in awareness now with cardiac screening and certainly in professional sport, it's something that's very standard. I think well done now. So young athletes, I suspect, most get some kind of echo or some monitoring as part of that, and an assessment. Again, it's the balance between we do hear obviously of the very sad events every so often of young teenagers, sporting teenagers who have collapses, and in retrospect probably have something like a congenital heart problem, but I suppose it's the balance of where the risk, the incidence of it over the risks of screening and the increased workload for that, and how to focus it.
And to go back to a practical day-to-day question, it's amazing amid everything else that happens at the front door that you manage to do research projects. How did you actually get it to happen? And it's probably doing the longer hours than you're contracted to do and everything else. But how did you manage to get the group together to do this?
It's been a long journey, and many years with myself and Alistair Gray in the making of building up from 1 or 2 research nurses at the beginning back in 2008 to where we are now with a large team. I suppose a lot of our research nurse funding comes from charitable bodies. So, for example, the BHF, and other studies, some of our stroke work that's obviously funded through stroke charities, which enables us to have dedicated research teams to be able to recruit to studies out with the clinical teams, so they're not tied into clinical work as well. So that's important, but that obviously has taken a lot of time to build up over the years, but is even more necessary now with how busy the department is. And we're finding that with the Aspired study, we've got 30 sites now across the UK doing it, and they're all experiencing the same level of busyness and managing patients in the department for 20-30 hours. And a lot of them are not as lucky as us to have such a great team and such a large team to recruit, and relying on a research nurse and the clinicians to be able to identify and recruit these patients. So yeah, it's about trying to champion research, to try and tell people the good stories and the benefit it has on patients. And we've seen locally as well the benefit that research can have on the clinical care. So lots of the work we've collaborated with Nick Mills, for example, in cardiology, looking at troponin. These patients used to be admitted overnight for troponin, come into hospital. Now we're ruling out patients within a couple of hours of the ED of troponin, all through research work. We did a study a few years ago on using TXA for epistaxis, so tranexamic acid in epistaxis. And retrospectively, we were managing these patients really badly. So when we had to draw up a protocol for managing the patients, which then included the trial intervention, we actually had no patients to take part in the trial, because actually when we managed them properly and did the evidence-based care for them, there weren't that many patients left who still had an ongoing nosebleed to give TXA to. So just by doing the trial, the management of our patients with epistaxis has improved tremendously, and we've got a great protocol now. And that was not only us, it was all the other studies, all the other centres that took part across the UK for that. And that's just one example of where research can really impact and improve patient care.
And how does it land with the patient? I distinctly remember as a cardiology SHO at the Old Royal in the early 90s, randomising or consenting patients for a trial that was a drug called Reotherix, which the research nurse used to refer to the patients as, it's soapy liquid for your coronary arteries. The idea was it was supposed to clean out the atheroma, and it being really challenging. How do the patients feel about being asked at the front door to take part in research studies?
So interestingly, you would have thought this is very challenging, but in fact, it's not something we find difficult, and we're able to recruit to studies in patient groups who previously we might have felt would be very challenging. So patients who come with acute mental health crises, with overdoses, for example. So working with James Deere on work on paracetamol poisoning. And again, these are patient groups that we might have thought would be previously very challenging, but in fact not. In fact, the hardest bit is for staff that are not used to work, research staff who are not used to working in the emergency department, to not fear approaching these patients, and also the environment. So we've done trauma studies where you'll have a patient come in with massive trauma, and as the research nurse, it was important to speak to the trauma lead at that point during the resuscitation to ask them whether the patient they felt was suitable for including in a trial. Only a minute's conversation, and all the trauma team leads knew about it and knew what's required, but it does require a certain kind of person who would approach a trauma team lead during the middle of a large code red resuscitation to ask whether they would be happy for patients to be enrolled into a research study. So that's a challenge as well, and that's why our staff are very used to working in the emergency department and have to be quite comfortable with doing it.
And do you have posters up in ED saying, we are doing these research studies, please ask us, or you may be approached about helping with some research?
Yeah, absolutely. This is a really new area of work. So the Royal College of Emergency Medicine have set up the TURN group, which is a trainee emergency research network. And the idea was to try and answer some of these questions where we want to recruit a huge number of patients to a study that could answer a question. So over a week, we recruit 5,000 patients across the country to something. For example, subarachnoid hemorrhage was one that they've done recently. And we're really looking into novel ways of consenting patients. So most of them are just data studies, and most of the consent will be about having posters up in the department and for patients to withdraw if they don't want to be involved, or for their data not to be involved. And that means that we can recruit almost everybody who presents with the condition, which makes it viable to ask the question, to answer the research question. And so we do, on some occasions and for some studies.
And do you think there's scope for ED research to be put into some of our favourite soaps, such as Holby City and Casualty and whatever? Again, to raise the profile. You know, we all talk as clinicians about trying to use what people see on a variety of media outlets to influence their understanding. You know, we all joke about the fact that if you're admitted to Holby City and cardiac arrest, 10 minutes later you're sitting up having a cup of tea reading the newspaper as if nothing had happened.
Yeah, that's a really good thought, Leslie. I think I've probably made it my mission now to get on to my friends in Bristol to see whether they would get someone from Casualty to be enrolled into the Aspired study during the episode of Casualty. I'll see if I can get that to happen.
Well, we look forward to the update if you're successful. But you know, we've certainly talked in various settings about, you know, leveraging the power of media outlets to improve patient understanding and education and whatnot. So there you go. You can get the Bristol Aspired team to work their magic. And see how you get on. Matt, we have worked you really hard. Thank you for an absolutely brilliant presentation. It's fascinating to hear what is happening, and I think, you know, we're all in awe of the fact that you have grasped the challenge of doing research at the front door amid all the other pressures, and it's great, and also the fact that some of the research is actually improving patient care, as you say, by having a proper nosebleed protocol. And again, it's encouraged you probably to speak to ENT colleagues and sort things out, and it's probably made their life much easier, as you probably have for the cardiologists, by doing things like Aspired, because people then go home and you're actually getting good quality data. So we wish you ongoing success, and many congratulations again on your appointment as Professor of Emergency Medicine.
Well, thank you ever so much for giving me the platform to be able to talk about our amazing team and all the great work that they do.
Thank you.